Dr. Patel, Dr. Simi Patel of Texas A&M School of Dentistry is going to talk to us today about dentistry's role in the opioid epidemic and the pharmacology of methamphetamines. Dr. Patel has 21 years of experience providing dental care to patients, many of them from vulnerable and at-risk communities. She has delivered care to most of the homeless shelters in the Dallas area and has served patients who are homeless, victims of domestic violence, victims of sexual trafficking, recovering alcoholics and drug addicts, and inmates. I qualify in at least one of those categories, but I'm not going to say which one. Additionally, she teaches third and fourth year dental students at Texas A&M School of Dentistry and in their extramural clinics at Agape until 2021, North Dallas Shared Ministries, and the MC Cooper Clinic. As of March 2021, she is a tobacco training specialist and received her training through the Mayo Clinic in Rochester, Minnesota. Welcome, Dr. Patel.
Thank you. So I'm going to discuss opioids in dentistry. And I have my contact information in case, you want to contact me later. I was just reason I put this picture up there is just to show you that, does anybody know what that is? A picture of? That's the crystallized form of methamphetamine as we know it. And I just thought I'd like to put that up because it kind of looks pretty. So on the timeline, methamphetamine was first synthesized in liquid form by Japanese chemists in 1893. Patented for, then it became crystallized in 1919. Patented for distribution in 1921. But the key here is in World War II, both sides. So the Germans, the Japanese, British, and US used it on their soldiers used it because it kept them alert. It prevented pain, prevented hunger, prevented fatigue and thirst. And the FDA also had made it a prescription drug by then, before World War II. And it wasn't considered a social problem until the 1960s. So it did take a while. And I'm not going to go over too much on the pharmacology, except that the onset of action, I want you to remember, so, it takes 2 to 3 hours if you take it orally, but if you take it intravenously, snort it, or smoke, it's pretty rapid. It works rapidly compared to cocaine. But the key thing I want you to remember is the eliminations is 12 hours. And if you have, in cases of toxicity, it could be 24 hours. And for dentists, that's very important for us to remember. And we're going to get to why that's important. So I have this slide here. I think most of us remember seeing this at one point when I remember it when I used to visit loved ones in the hospital. They'd always have this. And this really, we always want to keep our patient at zero. And these signs, I think, and it's been written many places that this fifth vital sign and the desire to alleviate pain has led to the marked rise in opioid prescriptions. And this was published in 2018. So we know that, we were going above and beyond, try to prevent patients in pain. Even European countries weren't going this far. So, you could say that, we started this. And then furthermore, in a study, U.S. dentists often prescribe more than the recommended quantity of opioids for pain. They were likely to prescribe stronger ones. And research on approximately 550,000 adult dental visits between 2011 and 2015, which is a pretty big study, revealed that over 50% of the prescriptions for opioids were longer than the three-day supply recommended by the CDC for acute dental pain. And 29% of patients were prescribed stronger opioids than were needed considering the procedure performed. And that was published in 2020. So it's still a problem. So some of the screening tools for dentists, I say the easiest screening tool is your medical history. And the ADA acknowledges too, this is from taken straight from the ADA website, the American Dental Association. It's patients may not feel comfortable disclosing that they're using opioids, Suboxone or methadone, but they also acknowledge that adverse outcomes can occur if you don't take a proper medical history, and that some drugs can affect postoperative instructions and healing. Medications or drugs may interact with anesthesia. Some drugs may affect dental treatment or other health conditions patients may have. And ultimately, it's the dentist's responsibility to obtain, maintain, and review a patient's medical history. So I looked and different dental practices we know have different medical history forms, and not all forms ask of previous substance use, um, you know, of previous use. So it's very important to have that on there. And if you see it, don't ignore it. And one of the questions I asked on the medical history is, I guess when we're getting closer to treatment, and I know I'm going to have to, and we're going to get to that slide, but about local anesthesia in particular, I'll whisper. It's important for you to tell me if you've used it in the last 24 hours, or you can have a cardiac event in the chair. And I don't want to send you home on a stretcher or, send you to heaven early. I always tell them. So it's very important that we get and usually they start talking then, but your medical history is a really good screening tool. And that's where I would start. We do risk assessments in our clinic due to the different grants we're on. But I do believe that it is very important that we start with the medical history. Other red flags. So you'd wish the red flags were this easy. I'm gonna play this video.
Christmas without beer is like Easter without beer.
So you wish it was that easy, but a lot of times it's not. So some of the red flags, obviously, previous history of addiction. You want to start there. I'm gonna put alcohol and tobacco use there, because on any patient, even if it's just tobacco, does that mean that they're I'm no way implying that they're automatically a drug user. That's not what I'm saying. But I am going to find out, how frequent are they using it with alcohol? How much alcohol are they using? Because they may think it's minimal, but if you're having several drinks every day, 7 days a week, you might have a problem. And remember, those are the kind of the diving boards, the leaping boards for people to. They tend to engage in more riskier behaviors. So, like for example, when I have a 15-year-old who tells me they're a smoker, I'm going to try to talk to them. I'm going to use motivational interviewing to get them to stop now, because I don't want them to start, it almost, when you don't address it, it kind of makes it okay. And then they'll start going into other things because they're going to start engaging in more riskier and riskier behavior. So if I can stop now, we can prevent them from picking up other addictions. The other thing, I'm looking at mental health. That's very important because we know that a lot of people with mental health, psychiatric conditions, mental health issues will tend to abuse not even just prescription drugs, opiates. That's their, they're more susceptible. I'm gonna look at the patient's disposition. If when possible, I like to stand in the hallway of my practice. I'm watching that patient when they walk in. I'm watching to see, are they trying to walk into walls on the way into the dental chair? That's a red flag. I'm looking at their arms. That's a good time to look at their arms. I'm looking at, do they have a lot of bruising? I look at a lot of things when they're walking in. Are they wearing short sleeves, long sleeve? It might be the gait. The other thing is multiple surgeries. Maybe because a reason I say that, when I did my PMP, we have to do PMP searches for those of us that can prescribe opiates. And I have not prescribed opiates in a while, but I still do my PMP search on patients. And it's funny because and one day I decided to do a couple of searches just to know, and both of them were taking opiates. And a lot of it was because of multiple surgeries. So the real red flag, the nice thing about being a dentist is the real red flag is we know who's abusing methamphetamine in particular, because they'll have dry mouth, a worn dentition because of the anxiety that methamphetamine causes. They tend to brux or grind their teeth. So their teeth are worn. And I'm going to show you a good picture, and then just rampant decay. Go to the next slide. Let's see.
Oh, man.
Oh,
Christmas
sorry,
up here
guys.
is like,
Okay, so I have to address this meth mouth. It stigmatizes a dental problem that the public and media link with methamphetamine use. There's no evidence that methamphetamine causes tooth decay and dental problems. It's the lifestyle changes caused by methamphetamine. Remember, you're on a high for a long time. You don't make the best decisions. You're going to choose that high carb diet. It's going to be a definite lack of oral hygiene. And methamphetamine directly prevents a stimulation of the salivary glands. And we know saliva has a protective effect. It helps you swallow food. It helps prevent cavities, So these people have decreased saliva because of, they're dehydrated. The anxiety contributes to teeth grinding. And if smoked, it can cause decay and enamel destruction, just like if you tobacco, e-cigarette use, and marijuana, though. Except when you smoke, it tends to affect the outside and the inside of the smooth surfaces of the teeth, and that's kind of that characteristic look of a dentist knows who's using methamphetamine, I would say. And the treatment approach is to remind one of the approaches that we remind our patients who use methamphetamine to set alarms to remind themselves to hydrate with water, preferably, or maybe like what is it? Non-sugary, like water, the carbonated water. I don't like the sugar substitutes that much, but yeah, that would be fine. And brush their teeth twice a day. And we tell them to set their alarms. So I say treatment in general for anybody on that is taking drugs, or remember, consider same day treatment to manage acute pain. The regimen of an antibiotic plus a narcotic, that is outdated. We don't do that anymore. Take care of that patient's chief complaint that day. I tell the dental students all the time, they're coming in, even if they're swollen. Obviously making sure it's not spreading through the fascial spaces. Then, of course, we might need to do IVA antibiotics or something. But if they're swollen, I'm going to try to numb them up, give that anesthesia time to work, and see if I can do something to get them out of pain that day. It doesn't make sense. Narcotics really don't, and the ERs and EDs are notorious for giving antibiotics and narcotics. I wish they would do CE with a dental provider to see how that is not that doesn't work. For patients with a history of substance use disorder, we tell them to we always say consider your choice of local anesthetic. That's what I'm talking about. Remember, the elimination is 12 hours for methamphetamine. So if I'm gonna, and remember, these patients don't get numb that quick, because when they're off their these methamphetamines, their pain receptors are constantly firing. Like they have a lower threshold for pain. Dentists complain all the time. They have to use more anesthesia that wears off faster, and all that, because when they're on methamphetamine, they have all that dopamine, right? So going, that methamphetamine really masks pain, and so we have to use more anesthetic on these individuals. So because the anesthetic of choice is epinephrine, because it holds the local local anesthetic in place. We do have local anesthetic without epinephrine, but on these individuals, it doesn't. It tends to. I told you the problem is that the anesthetic wears away quickly, so it's very important to find out if they use it within the last 24 hours. If they say no, I'm going to choose one with epinephrine, preferably, and the cardio, the blood pressure, all that is within a good range. I prefer to use one with epinephrine, especially most of the time you're taking out teeth on these individuals, unfortunately. Then I would tell you that after we're done with the procedure, to manage post-op pain, because that's when they're going to call you and say, I need something stronger, doc. So I'm going to go ahead and put Marcaine in, a long-acting anesthetic. because that's going to hold it. That thing, the Marcaine will hold them for about 7 hours. So that's how you're going to get your ibuprofen and Tylenol to work. Okay, even though we know ibuprofen and Tylenol work, but people have it in their minds that it doesn't work. They've got it because they've used stronger things, but evidence-based data shows that ibuprofen 400 milligrams and acetaminophen 325 milligrams, and I tell them to take it together, is superior than opiates alone for management of post-op dental pain. If narcotics are indicated, and I have not prescribed them for a long time, you always have to check that pharmacy website, Texas PMP. You're supposed to do a search. However, when I went on the statistics for 2022, I don't think dentists were checking it as often as we're supposed to. The number, they have the statistics on who's checking their website, and it didn't look good. And the other thing is avoid using or prescribing Paradex. It's chlorhexidine gluconate and those recovering from alcohol addiction. I did not know that. They did not teach me this in dental school. It wasn't until I was in a CE that they said, you better be careful because if you give a recovering alcoholic Paradex, it can make them relapse really quickly. So there's a lot of things, you have to consider. And I always say phase 1 treatment, meaning extractions, root canals, getting them out of pain is what we would do first. But remember, a part of their healing process is anybody in treatment, dental treatment is part of their recovery, because within methamphetamine in particular, every time they look in the mirror, it's a reminder of their addiction. So it's really important we help them transition pretty quickly back into society. Unfortunately, with methamphetamine use, it's mostly extractions and dentures. We're usually at that stage because I told you the lifestyle doesn't help. And then have a referral source ready, for those that agree, when you do your motivational interviewing, who agree to seek treatment. We have the government website. And I would say call them if they say yes. Put them in your consultation room, call them and make sure they're talking to someone before they leave the front door. And then we have, our recovery network too is a great resource as well. Also, I would say for treatment, we talked about, same day dental treatment. We talked about, talking to a nutritionist, if because we need to make sure that they understand it's not methamphetamine that's causing their disease. It's the habits. And we need to talk to them about hygiene is very important. And, so it's very important that when those that are seeking treatment, we try to help them adjust back really quickly. And again, dental treatment is part of their recovery. Anybody who is in seeking treatment from any type of addiction, really, because every time they look in the mirror, that's just a reminder of what they were doing. And I had promised you a picture. This is what you're and this is what I was talking about. And when it gets to this, and the sad part is, you'd be surprised how many patients think that we can fix this by, putting a crown on it or a filling, or they come up with all kinds of things. And first of all, I would tell you to fix this. Taking out these teeth are not easy all the time. There's nothing to hold on to. So a lot of times it's a good surgery. We have to sometimes remove bone to get these teeth out because they break. We have to obviously, what we call reflective flap, which is just make incision around the gums, make sure we can see down the root and take these teeth out. And when we take these teeth out, we'll have to also sometimes make sure we smooth the bone, and then we'll put some stitches in. Wait for healing. This person probably I haven't looked at the bottom teeth now on this picture, but I would imagine they would need for sure an upper denture. These are the upper teeth. So this is one of the things that dentists really can tell with, and particularly methamphetamine. We know this is, this is usually what we're used to seeing, unfortunately. It's not by the time they come and seek treatment. And we have to remember that dental care in America is not affordable. Not everybody has dental insurance, even those that have dental insurance. I mean, I think the coverage is really bad. It's not like medical insurance, you're still paying a lot out of your pocket. And if you have something like this, easily, a lot of it is going to come out of your pocket. And that's kind of the sad part of in all of this. Um, I am done. So if there's any questions, I'm more than happy. I'm gonna look at the chat while if anybody wants to ask any questions.
I have a question. So, I had gone to one of the PMP trainings just to sit in through it, and it was that required 8-hour training for physicians. So how do they track it? Like when you go in and look, is it tracked that you've gone in and looked, or?
So yes. So when I go in, it'll say, it'll tell you the date and the patients that you've looked up. Yeah,
Okay.
so that's how they track it. And I think they recommend those of us that can't seek out, because I stopped prescribing. I think our Dean of Clinical Affairs probably sent us an email. I want to say it was shortly after I was hired, but about let's say 2014, 2015, he made a recommendation that we don't prescribe narcotics to any of our patients, whether we're on main campus or off campus. And we know ibuprofen and Tylenol, let me tell you, it works. I had surgery in December. I mean, they cut into my abdomen, and I can tell you, I was determined not to take narcotics. And the doctor, told me I would need it the first night. And I didn't want to take it, but my husband said, please take it the first night so you can get up, and walk. And so I did the first night, but after that, the Tylenol and ibuprofen, I used it. So I only had to take one tablet, and that I was covered the ibuprofen and Tylenol. And I took it every 6 hours. I set my alarm, and I didn't have anything. I mean, so, ibuprofen for tooth pain, I would say is really good. As it helps with inflammation, and then the acetaminophen is there, to help too. But yeah, I would tell you that if you do a surge, I think they recommend at least on one patient once a year, which is not a lot if you think about it. And if you're like me, I check in December, which is really bad. But the 2 patients I told you I checked in December, both of them were. So I'm like, oh, I need to check more often, because they're not disclosing all this all the time.
Well, because you brought up a really good point, as you're looking at training, dental providers with expert, having some advocacy for using the PMP in there. And I love, and I think Carly had noted it too, just your talk about kind of harm reduction strategies for people that, that do use drugs and need some, how do you treat some of their oral issues, and how do you help them help themselves? So I really appreciate that perspective.
Dr. Patel, I wanted to weigh in on the ibuprofen Tylenol deal. I had a dentist there in College Station. I moved from College Station down here to Victoria in 2009. So this is going back probably 15 or 16 years. There was a dentist, and he was on that little side street across from Montelongo's jewelry next to the Fox and Hound. And he would not prescribe narcotics. He had a little envelope he gave patients, and it had 4 Advil and 2 Tylenol in it. And his instructions were to take that, and then every 6 hours rotate, either take a couple of Advil or a couple of Tylenol, and switch every other hour. And just recently, guess what Advil has come up with?
Yeah, the
Dual
Advil
action.
plus Tylenol.
Dual action. It's great. It's really great. I just had a shoulder replacement surgery. I take that more often than anything. And, so you're correct. And that guy knew it a long time ago.
Yep. I remember in dental school, they told us that does work. And so, I mean, I just never really got in that, habit of, I was not a big proponent of opiates in the first place, and I remember just hearing that all it takes is one, all it takes is one from, some individuals. And so, that's scary enough.
Yeah, I remember distinctly because I was so angry when my son had his wisdom teeth removed and they handed him a bottle of 30 hydrocodone with one refill. And I'm like, why would my son need 60 hydrocodone for
You
a
wouldn't.
wisdom tooth extraction? It made me so angry. He didn't get any of them. I didn't give him any of them.
Yeah, there's no need. There's no need for that. We take out wisdom teeth all the time in a community clinic. We don't have specialists. So, and we have patients that can't, I mean, they don't have the money, and we're doing free treatment, right? So, and none of them call back. Very few of them, I should say none, but very few call back and state it was, well, the ibuprofen and Tylenol didn't work. Now, if they smoked after their procedure, they probably have a dry socket, or you can always predict who's going to come back with some sort of pain. Because they didn't follow a single word you said. But it doesn't happen that often. But when I asked him, did you take, when I because I give it to him in the office, the ibuprofen Tylenol, if they don't have it. And they said that most of our patients say, I didn't have any pain because we gave it to them in the office. So I think that's important to note too.
Yeah, this is Tara. I ruptured my Achilles. And so I had Achilles surgery, and I was the same way. I didn't want to take anything. And I actually alternated the two and never had an ounce of pain.
Yeah.
I mean, granted, they prescribed Tylenol with codeine. And even then, I know in my mind, it's like not as hard as Vicodin, but even then I didn't want to take that. And I was shocked I couldn't even tell you where my incision was. So it did its job. And we have friends that have surgeries. I'm like, hey, you may want to look at doing this versus the hard stuff.
Yeah, I'll tell you, in Europe and other countries, they're not experiencing an opioid epidemic like the US is. And a lot of it's because they're not prescribing the medications, and they're not going towards the stronger ones, that's for sure. And I think if you and I don't want to stereotype or anything, but if you've ever had any European patients, when I was in private practice, I had this German lady, and she refused even local anesthetic for like crowns, and I'm like, I have to cut your tooth down. And she refused. And I was like, at least take it for my sanity. And she's like, and she said, no, not even any local anesthetic. So, I mean, I just feel like, pain is viewed differently in our country. I think, and pain is not a bad thing. Your body is telling you something isn't right. And, but I think we're going above and beyond what we need to do. There's no need to go and prescribe stronger medication, all we're saying is consider the procedure done.
Thank you for your presentation. I just wanted to thank you also for bringing up the Texas PMP. We have a medication-assisted treatment program at Bluebonnet Trails, and our MAT provider always checks the PMP before prescribing medications. And many times we have, people that are trying to get on Suboxone that are currently taking, have just gotten opioids prescribed, or have multiple doctors that they've gotten prescriptions from, or are taking benzodiazepines, which is something that's, she's very, very hesitant on prescribing Suboxone when they're taking benzos. So there's a lot that you can find out by checking that. So she always does every time, she prescribes Suboxone to a patient. So I think it's really, really important. It kind of sheds light on things that the light is not necessarily being shed on. So,
And that's important to remember too, because
Yeah.
many of these individuals are not just using one, one product, right? So that's
Mhm.
that should be another red flag, is that, if, for example, if I have a patient even on tramadol, I'm already, inquiring if there's any other, medication, because, there's a lot of drug interactions and people are not checking. And so we're putting, people at risk for, if it's renal failure, liver failure. I mean, there's a lot of organs involved when you're with prolonged use of these medications.
No, so that's why I think it's really an important part that we can add to the, as you work on the dental modules to really talk about.
I have a quick question.
Thank you.
Is there a way, I know that you said the providers can go in, they check the PMP, but is there a way that I guess we can ensure that our providers are looking at that? Or is it only them to see?
Yeah, so nobody can log in except the provider themselves. That's the unfortunate part. Yeah.
Okay.
No, so that was a good question, because when we met with some CPS workers, they had the same question is, who else can look and kind of see where people are at, and it's only providers.
Yeah, I hope that changes. I think that needs to be changed, because
Yeah, because we can have a provider that's saying that they're checking it, and you would hope that they are.
but they might not be. You're right.
They may
I mean,
not be, and we just you kind of just want to ensure that that's happening. I mean, from my standpoint, I feel like that's necessary for if we have providers that are working and here and or wherever, that you can ensure that they are checking that, so that it's just a positive thing to do.
Yeah. And I'll just kind of tell you as a provider, a lot of times you're stretched pretty thin. So, and you think it just takes a couple of minutes, but like I'll be in the middle of like checking, and then there's times I get called because we have dental students, so when they ask for help, you have to kind of get up, and because you don't know what they're asking for, so sometimes you're in the middle of your search and you're getting up, and then you come back and you forgot what you're doing. So I mean, things happen, but you just kind of have to get in the habit of checking, especially when I would say, even when you're going over that medical history, if you have that other tab open, that's a lot of providers do that. They'll have two tabs open, right? In the chart, they'll have the chart open, and then they'll have that website automatically come up. So you could just put all that. You just need the date of birth of the patient, and the name is all I had to put in, and then and that list comes up pretty quickly. And I told you that the two I did in one day alone, they're both on something. One's from the VA, and they're notorious for prescribing. And on both patients, I mean, they were above 60. The other was like a HIV, and they're notorious for prescribing heavy doses of narcotics on our HIV patients too. Those, the fentanyl and all that. Yeah.
Any other questions? Well, thank you, Dr. Patel. It's been very interesting having you. We will incorporate some of these tools in our strategy to educate the counties and places that are in our catchment area. And I want to thank everybody for participating today. All right, everybody have a good time, a good day, and we will see you next time. Thank you.
Okay, thank you.
Bye-bye.
Bye.